For the second half of today, we're going to talk about liver diseases. First, I want to pose this question. Which of these is not a function of the liver? Which of these is not a function of the liver? Protein manufacture, lipid storage, detoxifying the blood, glycogen storage, or storage of excess glucose, manufacture of bile. All of them are functions of the liver. Many times we forget how important the liver is. With the kidney, I think it's a little bit more of a daily reminder because you usually urinate a couple times throughout the day, so you're sort of reminded that something's happening. Okay. Well, with the liver, as long as everything's working, there's no clue that anything's happening until something doesn't work correctly. So all of these are functions of the liver, and the liver is a super important organ. Again, you can't survive without your liver. And you only have one. Now, it is highly regenerative. Hepatocytes are actually extremely have an extreme regenerative potential. But they can't indefinitely regenerate. There is a limit, and we're going to talk about that. What's the point at which you're beyond the point of repair with the liver? So we'll talk about that. But before we get to that, let's talk about a couple of these terms. So you can see sort of some familiar pictures here. We've got a liver lobule that's shown on the lower left. We can see from the central vein. Remember, the venous circulation is actually kind of the main network within the liver. And we've got our different zones as we move away from the central vein. Up here on the right is this pathway that looks at senescent, which is a word that means worn out or no longer being used, red blood cells, also known as erythrocytes. And we recycle these products, right? We recycle these products by breaking down and getting rid of the heme. And that heme actually is converted to what we know as bilirubin. And eventually, the bilirubin is excreted in the fecal material. And that bilirubin is what gives fecal material its color. Right? So what would stool look like if it didn't have bilirubin in it? It'd be like a gray-white. Okay? That's the color of poop, really, without bilirubin. Okay? That's a clinical term, poop. Okay. We're not allowed to say it in my house, so I like to say it here. I say words here, and I'm not allowed to say it at home. It's kind of nice, right? Just let go, just let my hair down. Because my kindergartner corrects us if we use the word poop, because Mrs. Hayes, her kindergarten teacher, says that's not an appropriate word to use in the classroom. Okay. But in my classroom, we can use it. I should tell her that. Well, she could probably watch the lecture. It's being recorded. So, all right, jaundice. Well, so jaundice. So bilirubin is this breakdown product of red blood cells, and that's what you're seeing on this right pathway. Jaundice is a clinical condition where you get a yellowish color to the eyes and to the skin. Like the whites of the eyes become more yellow in appearance. The skin becomes very yellow in appearance, and this is because you have unconjugated bilirubin, or bilirubin that isn't bound up to anything. It actually preferentially binds to the albumin that's in your body, and that gives it sort of a yellowish color. So this is due to hyperbilirubinemia. How do you like that word? hyperbilirubinemia. Hyperbilirubinemia. So this happens in patients that don't have appropriate liver functionality because the liver plays such a critical role in converting and processing and get rid of this bilirubin. Cholestasis. Cholestasis is a disease where you have a decrease in bile flow. So bile doesn't flow from the liver to the duodenum. So the liver manufactures bile, and it is concentrated and stored where? In the gallbladder. And then it's released upon demand in a fatty meal into the duodenum, part of the small intestine, the first part of the small intestine, so that you can help chemically break down fats. So cholestasis is where that flow is not happening correctly. And you see this happen in patients that are in liver failure. Patients that have a liver cancer or liver failure, they'll have this cholestasis. It can be very painful. In fact, what's very common is to put in a biliary catheter. And these biliary catheters are introduced from outside the body. And then there's a bag that's attached to it to catch the bile, because it'd be kind of weird, like, dude, you're leaking, okay, if they're walking down the street without a bag attached to them. And it'd be like this green radiator fluid, like, leaking stuff, okay? So cholestasis is a real deal. Portal hypertension. This is high blood pressure in the portal veins. This is occurring when you have damage to the liver itself, and you get a buildup of scarring in the liver. We'll talk about that scarring here momentarily. Coagulopathy. Well, if the liver is compromised and it makes most of the proteins that are actually found in the blood that are coagulation factors, it makes all of them except factor VIII. So if the liver doesn't work well, you have trouble clotting your blood. You can bleed out from a small cut. Hypoalbuminemia. Now, the liver itself also manufactures all the albumin in your body. So if the liver is compromised, you don't make enough albumin. Why is albumin important in the blood flow? Do you guys remember? Back to the exudate and transudate lecture. Colloid osmotic pressure. Colloid osmotic pressure. So albumin is a really large protein that's manufactured by the liver, and it floats in the bloodstream, and it encourages, it stays there because it's too big to leave, and so it generates a large osmotic pressure head that encourages fluid to come back from the tissues into the venous circulation, and that's why you actually have the veins collecting a lot of additional fluid to increase your blood volume. So if you don't have a lot of albumin in your bloodstream, then you have a lot of fluid that stays out in the tissues and you become very edemic, right? Okay, so hopefully I've convinced you that the liver does some really important things. You can imagine what we're going to see if we look at problems here shortly with the liver. First, which of the following organs connect to the liver using the venous circulation? Small intestine, stomach, esophagus, spleen, everybody but the esophagus, or all of the above? All of the above. Okay? So the venous side is really the main side when we're looking at the liver. Okay, so let's look at some diseases now. If we look at the first one that we're going to talk about, ascites. Ascites is the accumulation of fluid in the peritoneal cavity. And I'm going to show you some pictures. You probably can look forward, but just wait for it. Now, what happens when the liver, when we get portal hypertension, we get liver dysfunction, we lose the production of albumin like we just talked about. And if you have a compromised colloid osmotic pressure, you don't have enough protein in the blood to encourage fluid to come back. Where does that fluid stay? It stays out in the tissues. Okay, so varices are distended veins. The veins kind of dilate out, okay, trying hard to collect as much fluid as possible and be a reservoir. You generate these distended veins, and you're going to, I want you to remember, I'll read my note, recall, if you're hypotensive, right, meaning your blood pressure is too low, you release renin. What does renin do? Do you guys remember what renin does? Renin is released by what organ? The kidney. And what's its activity? What do you guys remember it does? It conserves water, right? So you reabsorb more water and you increase blood pressure. Okay, so this is why we see the liver and the kidney kind of connected. So in this situation, if you become hypertensive at the level of the kidney and you compromise function of the, hypertensive level of the liver, you compromise liver function, you become hypotensive in the circulation because you don't have protein inside, all the fluid is outside the cell, outside of the bloodstream. Renin kicks in, the kidney says, ooh, I better conserve water to raise blood pressure because my volume is low. This is a positive feedback loop that gets worse and worse and worse. You want me to say that again? You have you have liver damage. The liver itself becomes hypertensive. There's scarring. That puts damage or stress on the liver. You lose its functionality. You decrease albumin production. You don't have albumin in the bloodstream. What happens to colloidal osmotic pressure? Goes down. If you don't have enough protein and high colloidal osmotic pressure in the venous circulation, does fluid want to come out of the tissues back into the venous pool? No. So what does the kidney interpret that as? My blood volume's low. I should release renin, conserve water, don't release it in the urine, raise blood pressure, and now we have this circulating problem getting worse and worse and worse. Okay? All right, so let's look at a couple of pictures. This is a patient, chronic alcoholic, and this patient has this ascites, these distended veins that you can actually appreciate. You can also see that they're edemic. They have all of this excessive fluid in the peritoneal cavity, in the tissues, because albumin production is compromised. If albumin production is compromised, then you don't have this colloidal osmotic pressure, and all the fluid stays out in the periphery. Okay, so when I was a kid, I always wondered, and I never put it together until later in life, after I studied physiology. Do you guys remember these pictures of kids, starving kids in third world nations? Okay? And they have like these pot bellies. Okay? This is called Korsakoff syndrome. So here's two pictures of these little kids, right? And you see these, on these fundraisers and things, and I always thought, well, that's crazy. I mean, why, if they're starving, why do they have these giant bellies? No one took the time to explain to me that's actually a sign of starvation. And it's because they're not getting enough protein in their diet that the body is actually trying to use up the albumin itself. Right? It's using any protein it can to create energy. And so albumin is a protein, so it's destroying the albumin. And these patients, like the chronic alcoholic, actually have this distended belly because of the lack of albumin. Korsakoff syndrome. Okay, so away from starving kids and back to alcoholics. Okay? Actually, it wasn't a joke. I wasn't trying to be weird. But it's kind of interesting how we see, these two clinical manifestations in two completely different patient populations. It's really quite sad. All right, alcoholic liver disease. So what is the point of too far? If I say that hepatocytes have a tremendous regenerative potential, what's the point at which it's too far and they can't regenerate anymore? right? We're going to go through three main stages of alcoholic liver disease. And each one of these stages is considered a disease state, a pathological state. However, there are some that are worse than others. So the earliest stage is what we call steatosis. And this is sort of a fatty liver. Steatosis is a fatty liver. And then we go from, so we go from normal liver and we expose a damaging substance like alcohol. That's the one that we're going to choose. We get fatty changes and we get a lot of fibrosis that happens around the venule network within the liver. Well, if we abstain from that toxin, it goes back. Ascites regenerate very, very well. Well, we also could continue to go from that exposure and get into additional exposure. Usually you move over into sort of our second tier, which is known as alcoholic hepatitis. And with alcoholic hepatitis, you start seeing some evidence of necrosis of the liver. You have excessive inflammation that takes place. You get what's called Mallory bodies. That's like these structures that are early scar in the liver. Early scar, but not permanent scar. And then you get more fatty changes. And we'll talk about the architecture here in a moment. Now, if this continues, you sort of move into this cirrhotic phase. Cirrhosis of the liver is the worst of the three. So, least, middle, and then the worst. And with cirrhosis, this is no longer reversible. You can see everywhere I took you, there were these arrows going backwards, except from here. There's no arrow going back. And the key with cirrhosis is this scarring that we see, just like what we saw with the integument, just like what we saw with wound healing and scar formation. Once you get that nodule that's fibrotic scar, like we saw in the kidney just in the last lecture, you can't go back. Okay, so let me try to interrupt your question. How come you got arrows that go this way and you didn't explain that? Well, every patient's different. So some patients kind of move directly from a normal liver into an alcoholic hepatitis, and then they move into cirrhosis. Other patients go a more gentle method. Some patients go from normal liver and just straight into cirrhosis. So steatosis and hepatitis are reversible phases. Alcoholic hepatitis is slightly more severe, but the pathway is not the same for every patient. Okay? Question?
Yes.
I figured that's what it was going to be. Okay. So if you don't come to lecture, you get really confused with there's like 17 arrows, like firing all over the place. So let me just repeat that. Normal liver. Well, are you going to go, there's no arrow that goes from normal to cirrhosis, right? So it's okay to have like a glass of wine or, have a beer tonight. It's like, because you're not going to go like bam, all right? Like, whoo, oh, right? It's not going to happen that fast. There is going to be this development, but in every one of us, it's going to look a little different.
Can you skip the hepatitis part and just go from the left and then down?
Yes, you can go. You basically could go from here to here to here. You go from here to here to here to here. You go from here to here to here. You wouldn't go backwards unless you stop the damage exposure. You with me? Okay, so this is where we're going to be for the remainder of today. Alright, this is where I usually get everybody's attention. Everyone wakes up, right? Like, uh-oh. I'm all of a sudden extremely fascinated with this topic. Because I have this friend that I want to share this information with. Okay, I know. I have a friend too. So, what are the risk factors? So the number one risk factor is actually genetics. So let me put this in context. After every segment of this course, I always have like a list, line of students or emails that come in. I enjoy them, but I'm worried that I freak you guys out. It's like, uh-oh. So just like with, we're going to get into the respiratory system next, right? And there are people that smoke cigarettes for 10, 20, 30 years and never develop lung cancer. Okay? There are patients that never smoke and develop lung cancer. Now, does smoking increase your risk of developing lung cancer? It's pretty well established. I mean, if you're not quite there yet. I mean, even the cigarette manufacturers have finally agreed that that's true. Okay? And they have lots of money to be able to say that it's not true. And they're finally agreeing that it is true. So it's not really debatable anymore that it increases your risk factor. But just because you don't smoke doesn't mean you're not going to get lung cancer. Just because you don't drink doesn't mean that you're not going to have liver problems. Okay, genetics is the biggest determining factor. The problem is you may not know if you have the gene for it. Okay, if alcoholism runs in your family, then there's probably a gene there. Okay, it doesn't, it's, that scientific evidence isn't too difficult to see. So the second biggest risk factor is actually risky use. And there's also other contributing factors of how you can get a hepatitis disorder, right, with like hepatitis A, B, C, or D. So I'm just talking about alcoholism because, believe it or not, in this population that's in this room and in the world, that is probably our biggest risk factor. Okay, I mean, hepatitis is a sexually transmitted disease. It's not nearly as dangerous as over-drinking. So risky use is usually more than 4 drinks on an occasion on a regular basis. Okay, so there's a cutoff of 4 or more, and then there's this sort of fuzzy zone of regular. What's regular? Like, 2 times a week, 1 time a week, 4 weekends a month, every day. Every day might be considered regular. Okay? I don't know people that would say that would be non-regular. Okay? But you can see that there is this gray zone. The other sort of fuzzy line is we have seen an increase in risk associated with binge drinking. So if the binging happens on a regular basis and there's a hangover every time, usually a hangover is pretty indicative that you drank too much. Most people wouldn't argue that. Okay? There's a movie about this if you have no experience. Okay, you can watch a couple of movies. There's like a sequel because some people didn't get it the first time, so they made like a second and a third. So if you have no experience with what we're talking about firsthand, just watch the movie. You'll see what I mean. So if you have a hangover, it's probably too much. Most people wouldn't argue that. Okay? All right, so what happens now that we're past that? This is obviously the most interesting information of the entire lecture, I get it. But now what happens? Well, the excessive alcohol consumption damages the kidney. It damages the microarchitecture. It damages these microtubules. The liver. It damages the mitochondria, and it actually messes with membrane fluidity. So let's take a peek at some of the histology at the microarchitectural level. Question?
So is that last slide saying that not having hangover is a risk factor? Or
No. Having a hangover is a risk factor. So if you're binge drinking and you're always ending up with a hangover, then your regular pattern is excessive. If you're having a social event and there's no hangover, so what ends up happening is, and we'll talk about this, your liver is detoxifying the alcohol. Alcohol is a poison. So you put in a poison, and your liver says, here comes the poison, I'm going to break it down. And the intermediate is what actually makes you feel that you want to drink more. So the buzz that you feel is from the intermediate. And so if you drink slow enough, right, your liver is detoxifying the poison faster than it builds up, and you don't feel the effects. So that's why you hear these quotes of, well, if you're drinking about a drink an hour, then you're probably not drunk, right? So if you're socially drinking, you're trying to figure out, should I drive home? And you count how many hours you've been there, and you count the number of drinks you've had, and if it's about a drink an hour, your liver is probably detoxifying at a rate fast enough where you're not feeling the effects of the alcohol poison. Okay? And of course, it depends on body size. So if you're smaller, your liver might not perform as fast. If you're larger, then your liver is bigger and it can perform. It's usually based on height, not necessarily weight. Just like the lungs. The size of the lungs are usually based upon thoracic cavity, and that's based upon torso size. Same thing with the liver. Okay. Was there another question? Correct. So morphological differences. So if we look at the morphology, we're going to look at what we see in each stage. So steatosis. Steatosis, usually we're going to see sort of an enlarged liver. Usually it's soft, it's going to be yellowish in color. We get cholestasis where the bile's not flowing. And we'll see some evidence of perivenual fibrosis. So early indicators that the liver is starting to change architectural shape. The alcoholic hepatitis, we see more inflammatory cells present. You see swelling of the hepatocytes because they're starting the necrosis process. And then you get these clear formations of what we call Mallory bodies. And so this is normal liver on the left. This is alcoholic hepatitis liver on the right. And what I want to point out is, do you see the nuclei, the purple dots? And then, I don't know if you can appreciate sort of the cell membrane, but these are swollen in comparison to these guys. So here's our hepatocyte that's swollen, and the extra pink that's showing up is this Mallory body that's forming. It's a change, an early scar, if you will. Reversible, but it's an early type of scar. Now, if we finish off and look at cirrhosis, and we're going to show you, I'm going to show you more of these pictures here in a minute. But if you look at a cirrhotic liver, you're going to see nodules. You're going to see fibrotic scarring. You're going to see areas that have shrank back because the scar is retracted. You don't see fatty deposition. You're going to see fatty deposition in steatosis and even in hepatitis, but you don't see the fat here in cirrhosis. Okay, so let's talk about why the alcohol is dangerous. And I kind of introduced this concept earlier, and we'll continue to talk about. So this is the pathway when alcohol is consumed in the body. We have alcohol plus NADH leads to acetaldehyde plus NADH. NAD positive leads to acetaldehyde and NADH, which eventually is converted into acetate. Acetaldehyde is a hepatotoxin. This one is really bad. This one is not so great either, because look at what it does. These two intermediates are the problem children. Okay, so you consume alcohol, and if you run this reaction too much, you build up these intermediates, and this is where you're feeling the effects. The enzyme alcohol dehydrogenase is what actually runs this reaction forward from the left to the right. NADH inhibits lipolysis, the breakdown of fat for energy, and it encourages storage of fat, lipogenesis. And so if you're consuming large amounts of alcohol on a regular basis, you're going to build up fat storage within the liver, because the liver likes to store fat. And you're going to see, and that's what we call fatty liver. You're going to see that. Now, this picture that's shown here is a picture that's shown of a patient that biopsy from the liver that is an alcoholic hepatitis liver, and they're getting fatty depositions. And this is all reversible as long as there's no scarring. All right, so you can see all of these large vacuole structures. If I back up a slide, here was the control, right? You would see evidence of this fatty liver in either alcoholic hepatitis or even in steatosis. Okay? Mallory bodies you only see in hepatitis. This one you're going to see in steatosis or in alcoholic hepatitis. Reversible, unless there's scarring. That should make sense now at this point. All right, so what's the largest risk group? Biggest risk group. The age group with the largest risk. How's that? Huh? 18 to 29. Okay? Happens to encompass college, right? I really like this slide because this means I don't have to worry about anything because I'm outside of that age group. Yes, I'm older than 29. Okay. Pathogenesis of alcoholic hepatitis, right? Here's our picture of malware bodies, right here. Swollen hepatocytes. Well, we've got this acetaldehyde. I told you that's a liver toxin. That causes necrosis. So if you have cells dying, you're going to stimulate an inflammatory response. You're going to recruit the white blood cells that we talked about early in the semester with inflammation. Right? TNF-alpha comes from these cells called Kupffer cells, and that is basically a liver macrophage.
What is
Kupffer cell. This Kupffer cell, see the green agitated cell? That is a macrophage in the liver. Okay? But this one's resting. Now look at it. Now it looks like, okay? So this is a fibrotic liver. It's activated. So these Kupffer cells actually get activated as a result of the inflammation, and they're resident within the liver, and then they start going doing their thing. And you guys know what macrophages are capable of now. Okay? Well, we also have cells known as stellate cells. And normally they're quiescent. They're quiet. But in liver fibrosis, they're activated, and they start creating all sorts of matrix proteins. They're like a stellate cell behaves like a fibroblast in skin. And so it starts laying down all sorts of scar as a result of this inflammatory response. Now, we're still reversible as long as we don't have excessive fibrosis. But if we move on and we look at cirrhosis, liver cirrhosis, kind of the most late aggressive stage, what does this remind you of, this picture that we recently looked at? Just in the last lecture. You guys remember that post-mortem picture of the kidney with kind of the bumps on the surface that I was telling you about? This is a liver post-mortem. Similar types of bumpy ridges. Let me dim the lights so you can kind of get hungry for dinner. Okay, and then this is histology, a slightly different cytochrome. Here what you're seeing is you're actually seeing the pink structures highlighting areas of fibrotic scarring. And this is the surface of the liver. So if you took a cross-section here, you can see here's a bump, here's a bump, here's a bump, and then here's kind of a big bump. And that's these little nodules that you're feeling. So you have fibrosis that develops after repeat stellate stimulation. The macrophages that are there, the Kupffer cells that are present, they release tons of growth factors that causes hypertrophy of the hepatocytes. If you repeat on a regular basis the delivery of this alcohol, you get more damage and more fibrosis over time. And that altered architecture facilitates portal hypertension. Okay, then we get all of these ensuing clinical results. Remember the patient laying down supine on the table with the belly like this? Portal hypertension in a chronic alcoholic. Okay, so back to this slide. How does this all fit together? Okay, normal liver's at the top. That's good. Cirrhotic liver's at the bottom. That's bad. This is not reversible. It's not reversible if you're seeing scarring like this, or scarring like what we saw even in that kidney sample that we looked at in the last lecture. Okay? Depending upon your genetic profile and your individual lifestyle, if you will, you're going to move into phases, or patients will move into phases of either steatosis and then to alcoholic hepatitis, and then over to cirrhosis, or they may skip one of the steps and just move on into cirrhosis. Again, fatty change, indicative of alcoholic hepatitis or steatosis, mallory bodies present, telling you it's a little bit more severe, early scarring, still reversible. Those stellate cells haven't been stimulated to such an extent that they're not going to remodel favorably. But once you get down to cirrhosis, you can see no arrows going backwards saying if you abstain, you'll rescue the liver. Question?
In the first two phases, what are like the symptoms that you have?
That's a great question. How about we answer the question and we talk about all three phases? So what are the clinical symptoms was the question. So in steatosis, you're going to get an enlarged liver. In the old days, they would determine this using tapping. Have you ever gone to a doctor that taps on your cavity? That's cool, right? That sounds good. Oh, wait, that's hard. Never mind. But they tap, and they can use this tapping and hear the sound coming back to determine size. Well, now we can put a probe on there and take a picture, right? So an enlarged liver, elevated bilirubin. Remember that mechanism of bilirubin? So if the function of the liver is starting to become compromised, bilirubin builds up. Okay. So those are the early stages. So you might see yellow in the eyes, right? Just look at it. I'm just kidding. Alcoholic hepatitis. Okay, now things have progressed. So you get malaise, general discomfort. They don't feel so good. Okay. Anorexia, lack of eating. They sort of substitute calories from alcohol for food. Weight loss. The liver is actually tender to touch, so that tapping now is actually going to elicit some discomfort or pain. Hyperbilirubinemia. So now the levels are not just a little high, they're actually starting to get clinically problematic. It may even be that they have to come in for blood cleaning. Okay, they have to come in for dialysis, not because the kidneys are problematic, but because their liver isn't getting rid of the bilirubin fast enough. Okay. Jaundice, obviously, that was the yellow eyes. You can see that as well. Alcoholic cirrhosis, now it's much more severe. So you see some of the same things on each side of the equation, but they get more severe as you move on. So alcoholic hepatitis, portal hypertension, the ascites, that distended veins, you get a lot of peripheral edema. This is a picture of the gentleman laying supine on the table with the big belly. Discomfort, weakness, a lack of energy, weight loss, and jaundice would be severe jaundice at this point. So now the skin is going to look yellowish, not just maybe the eyes. Okay? Answer your question? All right. Other questions? Whoops. All right, make sure before you leave